Hello, I am Doug Fishman, the Director of Gastrointestinal Endoscopy at Texas Children's Hospital and an Associate Professor of Pediatrics at Baylor College of Medicine. As the Chair of the Endoscopy and Procedures Committee of NASPGHAN, we are happy to bring you IQ=E, Improving Quality in Endoscopy, a colonoscopy module. This is a series of maintenance of certification modules for the American Board of Pediatrics. We have no faculty disclosures. Since the introduction of endoscopy to pediatric patients in the 1970s, many advances have been made in the performance of endoscopy. This curriculum will help GI physicians and surgeons to identify gaps in current performance of pediatric endoscopy. This is the first module designed to improve quality in the performance of colonoscopy. A quality endoscopy is one that is safe and efficient, makes a proper diagnosis, excludes other diagnoses, minimizes adverse events, and has appropriate documentation. In adults, several metrics for colonoscopy have been established. These are now based largely on recommendations from task forces and GI societies, such as the ASGE, AGA, and ACG, and subgroups including the Physician Performance Measurement Set. It also includes regulatory bodies and hospitals such as AHRQ and JCO. There are also evidence-based studies which serve as a significant role in evaluating current practice, and these are single-center or multi-center studies or database registries such as CORI and PEDS-CORI. However, the majority of these initiatives are focused on cancer surveillance, thus limiting their application to pediatric patients. The major quality metrics in adults include the pre-procedure sedation assessment, having appropriate indications such as bleeding or surveillance, cecal intubation rates, quality of bowel preparation, accurate description of findings such as polyps and other lesions, and the recording of intra-procedure events. The focus, however, is typically on polyp detection and cancer screening, thus limiting the applicability in pediatric colonoscopy. The CORI group evaluated documentation in over 400,000 colonoscopy reports from 2004 to 2006. They found 13.9% of reports did not include bowel preparation quality, 10% did not include comorbid status. They did note 96% cecal intubation rate, however, ileal intubation rate was not reported. They concluded amongst the centers there was a wide variation in reporting. In thinking about formal recommendations for pediatric colonoscopy, there are no significant established quality measures. There are differences in pediatric and adult colonoscopy, such as indication. We see more patients with inflammatory bowel disease and less cancer. There are different anesthesia risks. Bowel preparation can be more challenging. And we need to be more prudent about when and how we do procedures in younger patients. Finally, we are responsible for documenting certain aspects of the procedure. Thus, ileal intubation may be more relevant than cecal intubation compared to our adult colleagues. In thinking about quality in pediatric colonoscopy, the bowel prep quality has been limited only to small series. Children's Hospital of Philadelphia published a series of 60 patients that looked at both efficacy and time. They looked at cecal intubation rate and had a 93% success rate, and ileal intubation rate of 83%. They also reported the average time to the cecum in colonoscopies was 12.6 minutes. There's some preliminary data from the PEDS-CORI network looking at 21,000 pediatric colonoscopies, in which 56% did not document prep quality. When reported, though, it was good or fair in 80%. 13% of reports did not include an ASA classification, and intubation rates did vary significantly from 85 to 95% depending on procedure indication. These data regarding documentation suggest there is a place for quality improvement. Critical to building expertise, training in colonoscopy represents an opportunity to introduce quality to trainees. Included in recent pediatric guidelines for endoscopy includes recommending procedures based on indication, contraindications, and alternatives, counseling patients on bowel preparation and pre-procedure requirements, and to select and apply appropriate sedation and equipment. As we transition from trainee to faculty, competence becomes very important to be integrated into our learning. Those trained in the past, clinical practice has served as the guide for self-assessment, but we must learn to perform procedures safely, completely, independently, and expeditiously, interpret and describe endoscopic findings, integrate endoscopic findings into our management plan, and finally, to recognize and manage complications. In thinking about endoscopic procedure quality, we must think about both the pre-procedure, the initial assessment, informed consent, intra-procedure, and post-procedure, and each of these should be assessed at each time point during the procedure or even in the clinic before the procedure. When we think about preparation quality, there are several scoring systems, including the Boston Bowel Preparation Scale, on which 1 to 9 is best. There's the Ottawa Scale, 0 to 14, and for example, the PEDS-CORI system uses a good, fair, and poor. For the purposes of this MOC activity, we will divide preps into excellent, adequate, inadequate, and not reported. There is an emphasis on the consequence of inadequate cleansing. For example, if a colonoscopy is inadequately performed, we may miss detection of polyps, the procedure may need to be repeated, it may increase procedure or anesthesia time, and perhaps may increase the risk or severity of complications. One of the most important preoperative assessment tools is the identification of patient risk factors for a given procedure and the related sedation. The ASA classification system helps divide patients based on their physical status. ASA Class 1 patients are typically normal, healthy patients, whereas Class 5 patients are moribund, not expected to survive without an emergent procedure. We can also use these classes to help us decide on the appropriate sedation. Classes 1 and 2 may be moderate sedation. Class 3 patients require careful evaluation and decision, and Class 4 and 5 patients would generally benefit from general anesthesia. This is an important part of the pre-procedure assessment, and the documentation of comorbidities is also important. There are several caveats of the ASA classification system when applying them to pediatric patients. There are crude patient categories that don't capture complex clinical scenarios. A gastroenterologist may disagree with a nurse and with anesthesiologists. The ASA class is associated with increased risk of adverse events at endoscopy in adults, and it is useful as an endoscopic risk stratification tool as well as a quality indicator for endoscopy. In thinking more about the ASA classification, we know that anesthesiologists may label more patients as ASA2. In comparing anesthesiologists and endoscopists, 71% of endoscopists labeled patients ASA1 compared to 51% of anesthesiologists. One of the reasons for this is that they may consider gastroesophageal reflux in their decision-making, and GERD is not a systemic disease, so the endoscopist is less likely to consider that. Moving to informed consent. Informed consent is a voluntary agreement by a person with the capacity for decision-making to make an informed choice about allowing an action proposed by another person. This has transformed from an ethical to a legal requirement. All 50 states require informed consent. We have either professional disclosure or reasonable patient standards. Professional disclosures is that which a colleague would give the same whether they were a professional or a lay person. Parents or guardians must provide consent for minors or incapacitated patients. State law should be used for the age of legal consent or for a patient's capacity for decision-making. Information within disclosure should include the patient medical diagnosis and results, the proposed procedure and the reason for doing the procedure, benefits of the procedure, the risks and complications or adverse events associated with the indicated procedure, as well as the alternatives and prognosis if the procedure is declined. These should all be documented in your report. As we think about efficiency in pediatric colonoscopy, we think about a timely procedure. A longer procedure creates additional colonic air and thus distension, making complete colonoscopy difficult. There is also potential neurodevelopmental risk of anesthesia in young children. An efficient colonoscopy improves practice efficiencies and decreases costs from time-based fees, both from anesthesia as well as facility fees, as well as less waiting by upcoming patients. In thinking about risks associated with colonoscopy, commonly bleeding, cardiovascular, infection, perforation, or making a hole, as well as an incomplete exam, which may be related to preparation and visualization, the endoscopic skill in reaching the target, for example, the terminal ileum, which can ultimately lead to undetected or missed pathology, a delay in diagnostic treatment, or perhaps needing to repeat the procedure in some cases. There are also significant risks of sedation and anesthesia. In terms of rates of colonoscopy adverse events, there is one large series from the PEDS-CORI system incorporating 12 sites and over 7,000 pediatric colonoscopies performed on children under the age of 18. They reported a 1.1% complication report, and the most common complication was GI bleeding at 38.6%, followed by hypoxemia. These are represented as a percent of total complications. Overall rates were higher in patients after polypectomy, 2.3%. As you note, sedation was a significant component with hypoxemia, and it was the most common complication in non-general anesthesia cases. Bleeding in general anesthesia cases was the most common complication. It is also very important to document our identification of findings, whether they are normal or abnormal, making sure they are accurate, and making sure there is a record of these findings. Continuing our discussion with the intra-procedure components of the procedure, it is very important that we improve our colonoscopy competency. Taken from our adult colleagues, colonoscopy competency is a technical skill that is frequently defined as the ability to intubate the cecum. The 95% mark is used to maximize adenoma detection rates in adults for screening, and more than 90% is expected in all cases as a benchmark. Ileal intubation is considered an important factor in pediatric colonoscopy, thus increasing the rate of detection of Crohn's disease. In the Children's Hospital of Philadelphia experience, 2 patients were diagnosed that would have otherwise not been diagnosed due to ileal intubation. In thinking about documentation, there are several basic requirements. The final operative report must be signed, the informed consent must be obtained, and a timeout performed. The procedure planned and completed must be documented, any trainee participation should be recorded, and the post-procedure diagnosis should be documented, and thus we are held to the same standard as our surgical colleagues. Additional critical documentation includes the indications and findings. Procedure indications should be identified, and these are representative of appropriate procedure choice. It may explain the choice of procedure to the patient, insurance, and billing, as well as comorbidities and ASA status should be listed, again related to the risk of the procedure. Findings should be documented, and biopsy should specify the location. Additional critical documentation elements are related to procedure efficacy. For example, depth of insertion, which is typically the cecum or terminal ileum, as well as the time from anal intubation to endoscope removal, which represents the total procedure time. The time from anal intubation to cecum reflects the minimum expected efficiency for the procedure. Ileal intubation is the pediatric standard to maximize diagnostic utility and can be a measure of overall efficiency. And it is important to demonstrate documentation either by photography, biopsy, taken, or documentation. For the purposes of this MOC activity, we will divide preps into excellent, adequate, inadequate, and not reported. There is an emphasis on the consequence of inadequate cleansing. For example, if a colonoscopy is inadequately performed, we may miss detection of polyps, the procedure may need to be repeated, it may increase procedure anesthesia time, and perhaps may increase the risk or severity of complications. As we improve our quality in colonoscopy, we anticipate an improvement in outcomes. These will be represented for this module from documentation of adverse events, documentation of blood loss, whether that's none, minimal, or more than 10 milliliters, the documentation of discharge plans, as well as the change in management based on findings of the procedure. Did the procedure influence the patient and their overall care? For this MOC activity, we will learn more about our practice and those outcome measures. The % documentation of required elements, the total time of procedure, the total cecal intubation time, ileal intubation rate and time, as well as colonoscopy preparation quality. In thinking about methods of improving quality, we'll have self-evaluation reporting, the identification of benchmarks and standards. This will lead to additional training and education, as well as other MOC activities. The next steps include the MOC activity focused on colonoscopy, evaluating 10 consecutive colonoscopies, and completing a survey for each of the 10 cases. The format for this will be PowerPoint slide presentations along with accompanying video, reference lists, as well as clinical resources. In summary, variation in pediatric and adult colonoscopy exists. Improving documentation is a key step in improving procedure quality. Critical components of a report reflect on the overall procedure quality. Future studies are needed to validate specific benchmarks in pediatric colonoscopy. Future MOC modules will evaluate other aspects of pediatric endoscopy. Thank you for your attention, and I'd like to make special acknowledgement to these colleagues as well as NASPGHAN members. Thank you.